So, good afternoon, good morning, good evening, whatever the time is. You are welcome to the third and second to the last session of the Boost Learning session on Community Activation Dialogue series. Last week, we saw another opening by one of the groups. And today, we are going to have another beautiful presentation by the group, which is called the TEM group. For those who are coming in new, probably I'll just give you a small rundown for you to understand what this is all about. One, if you can see through the slide, addressing challenges on low coverage using community activation principles. And the TEM group, which consists of the T is for Tina, the H is for Hilarious, the E is Emmanuel, M is Munir, D is for Dorothy. So over 4 months ago, 20 professionals were called from different countries by the Boost community for a course which is called Advanced Community Activation. And in those 4 months, we had drilled ourselves into learning, and we have acquired more knowledge. And finally, we were into the last stage, which is called the capstone project. We're in our final project, and we've seen 2 groups which have presented, and then we're the third. And I'm sure we're having the 4th, which is coming on the 30th. Some came in through adaptive leadership. Some came in through the cohort of activation series. Some from storytelling, and that's how we came to 20. Now that 20 were divided into 4 groups. And today, you have a wonderful presentation by the TEM group. And over these months, we were drilled by these professionals, most especially the faculty, Peja, Nina, Zined, and from the Boost and Sabine Institute, we have Liz, MJ, and others who actually supported us into these processes. We want to say thank you. Actually, this is my opening, and I'm sure towards the end, somebody will probably say thank you to this wonderful faculty and trainers and coaches who have sent us into this session. So we'll start our presentation now by the opening of our presentation, which is addressing challenges on low coverages, which we know has been an issue. Yes, you could see vaccine. Yes, you might not see vaccine. So then you were trying to see if we can balance between the coverages and using so many methods, which you see by the presenters. So gentlemen, I want to please mute your mics. If you want, you needed to say something, you can either use your raise hand button, or you can send a chat so that we can be able to listen attentively. Thank you very much. Tina, over to you.
Yes, thank you very much, Emmanuel, for the brief presentation. Dr. Hilarious will be taking the first presentation. I give him the floor. Dr. Hilarious, please.
Over to you, sir.
Right. So, good day to everyone, and I welcome you to this session on addressing challenges of low coverage using community activation principles. Next slide, please. Okay, so we've joined the Boost community, which is a global community where immunization professionals connect, learn, and lead as far as issues of immunization are concerned. And we are throwing this invitation to those who are not yet members of the community to create a free account and be part of these global community where we all work together to improve on immunization services in our respective areas. Next slide. Next slide, please. Right, so this is the outline of my presentation. We'll talk briefly about the need to address the issues of low immunization coverage, have some key facts on immunization coverage. Then I'll give you, share with you a case study which outlines some principles of community activation in addressing issues of low coverage in a rural district in Ghana. Next slide. So let me share this story with you. I am the last of 9 children with my mother as a petty trader, and my father was a school teacher. With much of the burden for the upbringing on my mother, we all managed to become useful children, and I had purposed to reward my mom when I get gainful employment. While I was still in school, my mother had passed on from cervical cancer. And this was a disease that I know could have been avoided had she been vaccinated against the human papilloma virus. She never had the opportunity of getting vaccinated. A few weeks ago, a bosom friend of mine, a doctor, called desperately looking for an intensive care unit space for his mother, who had contracted COVID-19. I asked why she was not vaccinated. The response was that when she got the vaccines, when she got there, the vaccine had finished, so she didn't have access to the vaccines. Ultimately, she died, and again from a disease that could have been avoided with a shot or 2 of COVID-19 vaccine. While she couldn't get the vaccines, there are stories about vaccines expiring unused in other countries. There are many of you who have had similar experiences of loved ones, children, babies, wives, husbands, dying due to poor immunization coverages and issues of equity in the distribution of life-saving vaccines. This, we should all agree, that cannot continue. And it is for this reason that we are calling on each and everyone in this room to join hands to work in our small ways to speak up against inequities and low immunization coverages. If you believe that the vaccines save life and that vaccines must cover all, irrespective of their social or economic status, color, or creed, it will be useful to drop a message of solidarity in our chat box as we progress with these conversations. So kindly, if you agree that we all need to work together to improve on coverages of immunization for our children and for all, kindly say a yes in the chat box as we proceed with the presentation. Next slide, please. So according to the WHO, vaccination coverage is the estimated percentage of people who have received specific vaccines, according to the US CDC. And when you look at the key facts from WHO, the global coverage of immunization dropped from about 86% in 2019 to 83% in 2020. And this translates to an estimated 23 million children under the age of 1 year who did not receive basic vaccines, which is the highest number since 2009. In 2020 alone, the number of completely unvaccinated children increased by 3.4 million, and only 19 vaccine introductions were reported in the same year. And that number is less than half of any year in the past 2 decades. And about 1.6 million more girls were not fully protected against human papilloma virus in 2020 compared to the previous years. And these are all young girls that are still vulnerable to the infection and potentially can get cervical cancer. Next slide, please. Now, so I share with you a situation we encountered in Kratchi West District in the Volta region of Ghana. So the key challenge there was a low immunization coverage because, I mean, this is a peninsula with a third of its population located on island communities where there are no healthcare services. So technically, even if you're able to reach all children and all the target group inland, you're only going to get about 70% of your immunization coverage. So we had to come up with an organizing statement. We wanted to mobilize our healthcare staff, immunization professionals, including non-health actors within the district, to achieve at least 90% coverage for all our routine vaccines within 5 years from around 2013. So in doing this, we had to identify who the key actors are. So we identified clearly that we had key middle-level managers like disease control officers, public health nurses, health promotion officers who directly supervise the frontline immunization professionals like the community health nurses and volunteers. We had NGOs in health who were willing to provide support in immunizing children and other target groups. Right. And then we also have our political structures, the district assembly with assemblymen in every community. And each electoral area, which is headed by an assemblyman, is also demarcated as a community health planning services or an area that is assigned to a healthcare worker to oversee. So what were the strategies that we had to employ? Okay, so the key strategy was that we wanted to rely on our existing resources that come from the Ministry of Health for routine service provision. So what we did was to be able to divide the district according to the 21 electoral areas that we had. And so every resource we had divided it equally to cover these island communities that had no healthcare access, even though there are no healthcare facilities on it. And then we use these resources that have been allocated to those areas to carry out outreaches to these island communities. And whilst we do that, we wanted to be able to demonstrate some meaningful results with the little resources we have so that we can get stakeholder buy-in with additional resources to try and improve on the coverages in the district. Next slide. So based on this broad strategy, we engage in some specific activities to ensure that we're able to achieve our goal. First of all, we engage all health workers and managers to agree to devise ways to reach the unreached population within the district. We engage community leaders, assemblymen, NGOs. We reallocated existing resources in a way that ensures that our communities in the district receive immunization services. Now, one thing that it did for us is that it made sure that there was some form of dedicated funding at all times to these communities that were unreached and which were contributing to the very low coverages in our district. And then we decided that we usually hold quarterly performance reviews. So as part of the process, we use these performance reviews as capacity building sessions to be able to get our frontline health workers and all the people we're trying to activate to learn the ways in which to be able to get community involvement and other stakeholder engagement. So what was the results? Having done all of this, we realized that immunization coverages improved to over 95% within 5 years. And within the same space, we had communities and populations surrounding our district who found that we were trying to reach the unreached communities, also accessing their immunization services from our district. So over time, we were overreaching our target population for the districts. The initial results caught the attention of NGOs like Korea Foundation for International Health. We had USAID who also got very interested and started investing resources to sustain the outreaches and also build healthcare facilities, about 3 of them so far, on these island communities to make sure that on a sustainable basis, we have healthcare workers there and providing routine services. And then over the period, the district emerged at the top of the performance league table of districts in the Volta region at the time. And within this space also, we had a number of districts and a region that is very close to our district that had vaccine preventable disease outbreaks like polio. And our district, because of the high coverage, was spared any outbreaks because of the work that has been done. So I share with you some of the results in the subsequent slide. Next, please. So here we were comparing the blue bars refer to the regional coverages. This was a district, and the yellow ones looks at our district coverages. From 2013, BCG coverage was around 82.4%, but as of 2017, we had increased our coverages to beyond 100%. That is including other districts, populations that were beginning to access services within our district. And that outperforms the regional averages, from year to year. Next slide. So here also I share with you Penta 3 coverage. Okay, so again, as at the time of starting these interventions, the district was at an all-time low of 62.5 coverage for Penta 3. Okay, but as at the time of 2017, we've been able to move the coverages, reach the targeted population within the district, and also had other district populations accessing services on these islands that we were reaching over the period. Next slide. Now, generally, if you look at all the various antigens from BCG to Penta 3, Rota, TD2, the coverages have increased consistently over the period, to over 100%. Next slide. Right, so this was one case where we identified that we had low immunization coverages. We recognize the need to be able to activate all the key stakeholders that could work together collaboratively to ensure that we are able to reach the unreached population. And based on using community activation principles, we were able to move our immunization coverage from these all-time low to very high levels. And indeed, if we had gone through these community activation training, I'm sure that we would have achieved even better, because then we are approaching these activities with very clear principles that have been well laid out. And it's on this basis that I would encourage everybody who is in this room that at the next offering of the community activation training, we should enroll and benefit from all these useful principles that are helpful in addressing some of these key challenges with immunization coverage that we have in our respective areas. Thank you very much.
Thank you, Hilarious, for that wonderful presentation. And next, we're calling on Tina, who will be presenting in another aspect, because Hilarious did on how to activate and then how to, we're talking about coverage. Tina will look at the other aspect of how the...
Okay, thank you, Emmanuel Musa. Please.
The other aspect of... Over to you, Tina.
Thank you. I'm ready. Good afternoon, everybody. Okay, just a continuation of what my colleague has just presented. If we look at coverage, then there is a question that comes to mind. What are the reasons why coverage is not being achieved? So on that note, I was assigned to take the barriers to immunization coverage as one of the global challenges that is confronting immunization professionals. So I'll be taking you on the barriers to immunization coverage. Next slide. Yes, this slide is showing our chant, our vision, and then our mission as a team. We originally took the name termed as the community pillars. Vaccine save lives, save us all was the chant. And then our mission is to, we are sorry. So the statement there, I think I cannot really read it. The screen is covering. Let me try to see what I can do. Okay, the next statements are just statements, and I was not able to read that because of the screen. Okay, next slide, please. Yes, once again, I want to say thank you for participating. For all participants that are here, please, I would like you to just take 2 minutes to kindly type in the chat another word that you can use to describe the term barrier. Barrier is a very common word that we use as immunization professionals, but we want to see on the chat what you can say barrier is in another word. Obstacle, setback, obstacle, hindrance, limitation, hurdles, setback, wall, hindrance. Okay. Okay, we'll continue with the presentation. You just continue to type in, please, the next presentation, the next slide, please. So the content of the presentation starts with the introduction, which was the statements, the chants, and the vision of the team. Then we have done the test of participant understanding of the topic. Next, we will look at the outcome, expected outcome of this presentation, the key immunization barriers leading to low coverage, gender-related issues as it leads to low coverage, the strategies that needs to be applied, steps to develop a good ATOM map to address immunization barriers, definition of terms related to gender, call to action, breakout, and then the breakout rooms, feedback from participants, question and answer sections, sharing of experience, next steps, and announcements will follow. So let's go to the next slide, please. Expected outcome. Yeah. So at the end of this session, the participants are expected to identify key barriers leading to low coverage, interact with fellow immunization professionals to address issues that are leading to low coverage, share experiences, ideas, and make commitments to improve coverage with a special focus on gender impact in immunization to improve vaccination coverage. Develop ATOM map with key actors identified to address barrier to immunizations as it's related to individual context. Next slide. Now let us look at some of the immunization barriers that was listed in the presentation. We have vaccine hesitancy, we have gender-related matters, we have poor micro-planning and implementation, missed opportunities for vaccination, we have geographical terrain, we have vaccine equity, attitude of health workers, weak program leadership, we have a weak data system, we have insecurity, we have age and low educational status of the parents, and then we have, I can't really scroll down, we have social, cultural, and religious barriers. Can you scroll up a bit? Okay. So the question and reflection is gender-related factors in immunization. How does it lead to coverage, low coverage? So this is the question that should come to our mind. From the previous slide, the gender matter was highlighted in red because we as a team, we have agreed to really pick out one of the key challenges that we are facing globally, and which is gender-related matters. So the question is, how does gender-related matters lead to low coverage? That's what we'll be looking at in the presentation. Next slide. Gender-related issues in immunization. The gender norms that disempower and discriminate women. The gender powers and norms that disempower and discriminate women against, women. The gender norms that discriminate against women and girls have an impact on their health and right to health, as well as that of their children and families. These factors impact women's and girls' lives, including their access to immunization as TDs and HPV vaccine. To develop effective intervention for increasing immunization coverage, it is necessary to fully understand these different barriers, how they are compounded by other barriers as a result of additional social factors, such as socioeconomic status, disability, or across the rural/urban divide, and the levels on which they operate. Barrier, poor quality services, family factors such as single parents, families, and lack of daycare, female gender and financial barriers, as also limit access to primary healthcare services. Some other factors are cultural norms and value, gender imbalance, and poor power and authority to make decisions. These are some of the issues as it relates to gender barriers in immunization. It's focused actually on the gender aspect of immunization, where women are not having the access to healthcare facilities due to some of the norms, the values, and the culture that's where they find themselves. So these gender issues has actually affected coverage because most of the children we are targeting are mostly in the hands of these women. So we are looking at how we can, as a team, as we are here, look at that aspect of immunization, barrier in immunization, where we can have women to have power to make decisions to take their children for vaccination. Next slide. Next slide. So
it should be on the next slide. Can everyone else see that?
This is the slide. Sorry?
Yes, this is the slide. Okay.
This is the slide, yes. So having identified our key issues, which is gender, we are looking at how we can strategize. What are the strategies we need to put in place? We're able to identify to reach the zero-dose vaccination, to use zero-dose vaccination strategies. Zero-dose, we are looking at where countries will be committed to vaccination of all, using and systematically using equity indicators during planning, service delivery, and monitoring to track progress in equitable service delivery. Vaccination Stakeholders must identify, understand, and address the determinants of vaccination inequality and remove cost-related barriers to vaccination. To improve coverage and equity, aims to extend immunization services to reach 0 dose. Those who have not received this first dose of DTP vaccines and under-immunized children and communities. Reaching these children means reaching the missed communities. They are a part of. These unprotected communities are not only potential epicenters of disease outbreaks, they are also often deprived of other basic services and suffers from entrenched gender inequality. So 0 dose, reaching 0 dose is one of the strategies we are going to use so that we can actually resolve the issue of low coverage. Then also we have gender responsiveness to immunization. These strategies will address gender-related barriers and the specific needs of women and men in health services, advancing gender equality and increasing women's meaningful participation in the design and delivery of health services are needed for advancing the SDGs and the universal health coverage programs. So these women are key delivering of the UHC program. That is why we are now putting it as we are now recognizing it as one of our change agents to make sure that we are able to make impact even at the global level. Okay, so the third strategy is to also look at a method of collecting information about differences in the needs, participation, access to control over resources and decision-making power of women, men, boys, and girls in their assigned gender roles. So these three, we actually, next slide, please. These 3 strategies I can say was really given to us during our IA 2030 courses that we just finished. So the next strategy is the ATOL mapping strategy to address immunization barriers. Why do I decide to use this? This actually was what was one of the skills that we achieved from this advanced training on community activation. We were really told about ATOL mapping, how we are going to use it to actually address some issues. So the ATOL mapping model, this will identify all the key ATOLs that needs to be considered in order to address a specific barrier. Then the key steps, what are the key steps to develop a good ATOL map? One of the steps is your constituency, which is the potential leadership. Number 2 is the supporters. Number 3 is the opposition. And number 4 is the supporter. Number 3 is the supporter. Number 4 is the opposition actors. Next slide. So this is the model. This is a model of the ATOL map. If you look at this, we have 1, 2, 3, 4 models here. The first one is the constituency, and under constituency, we have potential leaders. Then we go to the next ATOL sectors, is we have supporters. Then we have, sorry, next slide. So the competitors, and then the opposition actors. So what we do here is to have our who in the sense that who are you targeting? Who are you? Like today, we are targeting immunization professionals to support us. So we are activating immunization professionals to support us in increasing immunization coverage. So who are we targeting? This model asks the who's. And then when you have the who's in your head, then you are able to know who you are targeting. So the first place is the leadership. The leadership, which is the constituency. Are they the ones you are targeting? Then if they are the ones you are targeting, then you identify the leadership that you want to work with. Then if you have your supporters, who are your supporters to achieve that barriers, you identify them. Then your competitors, who are competing with you in the process of trying to achieve your goals. Who are your competitors? Then also you have those who are oppositions to you achieving your goals. So this model is used for planning and implementation and achieving strategized goals, barriers to immunizations and other issues. So for us to be able to use this model, we have to have ability to build relationship, intentional relationship. And if we are able to get the relationship set up, then we'll be able to identify all these key actors and then set out to plan and implement our strategies. So we already know where our positions are the competitors, our leaderships to work with, and then the supporters who are going to support us. So in the process of this webinar, we are going to look at how our participants can be able to identify key immunization challenges, then identify also who are their leadership, who are their competitors, who are their opposition to the progress of that achieving that goal, and then who are likely to support them. So this is one of the things we'll be doing in the breakout room later on. Next slide. So having explained gender matters, how to strategize, how to resolve issues, I just have some definitions here so that for those of us who might be new here and new to the platform, we'll be able to understand some of the key terms that were used. For instance, equity is concerned with all countries having fair access to safe and effective vaccines, vaccination supplies, and technologies consistent with vaccine preventable diseases, epidemiology, domestic capacities, human resources, and ability to pay for vaccine and services. Then gender, it refers to the socially constructed rules, norms, behaviors that a given society consider appropriate for individual based on the sex they were assigned at birth. Gender also shapes the relationship between and within groups of women and men. Gender equality. Sorry, can this one be scrolled up again? It's a bit down.
I'm sorry, Tina, I can't scroll down anymore on the screen.
It's okay, it's okay. Okay, so gender equality. Okay, gender equity is the process of being fair to women and men. It recognizes that men and women have different needs, powers, and access to resources, which should be identified and addressed in a manner that rectifies the imbalance, addressing gender equity and leads to equality. Gender norms refers to beliefs about women, men, boys, and girls through socialization, they change over time and in different contexts. Gender norms leads to inequality if they reinforce mistreatment of one group or sex over the other, or leads to differences in power and opportunities. Gender analysis identifies, assesses and informs appropriate responses to different needs and barriers, and asks critical questions to uncover root causes of gender-based inequality. Gender equality is the absence of discrimination based on a person's sex or gender. It means providing the same opportunity for each person, including access to and control of social, economic, and political resources, including protection under the law, such as health services, education, and voting rights. Next slide. Next slide, please.
Reduce the time. We're getting out of time, Tina.
Dear colleagues, thank you for listening. I will just give a call to actions for us to be committed to actions. Fellow colleagues, immunization professionals, our stories and the mission is not new to many of us present in this meeting today. I believe we are all witnessing the rate at which COVID-19 virus outbreak has led to the death of so many people, including our beloved ones, and the only hope is to escape the deadly disease is vaccination. We are calling on our fellow immunization professionals to use the knowledge and the experiences gained from the interactions today to get committed to the boost community attendance can be had for us to stand firm and focus on improving coverage and equity through gender responsiveness to immunization programs and community activations in our respective contexts. Thank you for listening. Next slide. Next slide.
Thank you, Tina. Thank you.
Next slide. Next slide. Thank you. Thank you for listening. So, thank you for listening. Emmanuel, please, can you go to the breakout room?
I'm not too sure if we have time for breakout room because we're running out of time. I don't know.
Yeah, we can do the breakout room. Yeah.
Yes.
Okay.
Please, can we have, is it possible? We're just having those 12 minutes now. We have question and answer session. So is it possible? If we don't have, probably we just go through Munir.
Hello, good afternoon all.
Yes.
Yes, so here actually the presentation was made, we have two different presentations made by Dr. Hellerus and Tina. Hellerus was able to come up with a narrative where he gave a quick story on the impact or the consequences of negligence towards immunizations, particularly to women. He gave a story where he lost his dear mother as a result of the human papillomavirus, which of course, if she was immunized on the right time, she will not have this kind of occurrences. Then secondly, another narrative story, which was trying to align it with the community activation, was on the issue of also COVID vaccination, which also his parents, a doctor, mother also lost her life as a result of a lack of vaccinations, which may lead to loss her life. And then, based on the presentation made by Dr. Hilarius, he was able to make a significant explanation on how the need of coming together as a community now to work together so much so that you can champion all the immunization processes and other community engagement acts. So pushing up to, as he pushed up, all the community pushed up to organize themselves, they were able to have some support from others. And I'm sure the use of community activation process may help in creating more coverage and in terms of immunization, as well as reducing the high number of vaccine hesitancy if at all the people come together and join hands together. And then the last presentation was made by Tina, which she was able to discourse on the barrier towards immunization. She was able to itemize all the possible barriers which may create a stumbling block to the success of immunization coverage. And also she was trying to look at the equity, the girls' rights towards receiving and other activities. She and what barriers are, and then what are equities, and then at the panel stage to capture this, to push it toward. She brought the idea of the actors map, categorically identified steps toward developing the activity, the actors map. And this map really, when you map and itemize and identify all those people who can give you a support, like the partners she mentioned, the opposition she also mentions, and even sometimes the troublemakers. When you know them, then you can rightly put each and every actor in an appropriate positions. At long run, then you can harmonize them together and have a success toward the goal or the objective that you designed to achieve, particularly in addressing the barrier as well as the immunization coverage. Still haven't saying much. She also tried to look at some stages. After the strategy, she looked at the 0 dose, how we are going to capture the 0 dose. And then she also talked how we are going to look at the gender responses. At the same time, she brought up the analysis, as I mentioned earlier on, where she talked of the mapping and other key steps that may help in creating a good social relationship towards succeeding to immunization process, particularly in the pandemic era, where we have in some countries we have a lot of hesitance to the vaccine because of the fear as well as some a kind of differences in a rumor and other things. So I think at the total end now, the main principles toward mutual activation is building a intentional relationship. You try to build relationships with other people, particularly using one-on-one meeting, so much so that you can create a good rapport, which may help you to move and mobilize people all along. So I think that's where I can stop. Maybe if there's any question, then we can do it in the. I saw Dr. Benedetta was able to make some points regarding the barrier. He said that it's not only on us, but we have to look at our. It means we not look outward, but we look inward. So based on the barriers, when you look at immunization, it is categorically divided into 3 stages. There are barriers which are related directly to providers, service providers. There are barriers which are vividly associated to the caretaker themselves, and then there are other barriers which are vividly to the system itself. All this, when you align them together, you will have some separate and different barriers, which of course, if you want to make your analysis or you want to make your intervention, you have to put all that into cognizance by identifying what and what, then it may give you a better room in developing your action, actors map and other appropriate actions that you're supposed to take. Thank you very much and over.
Thank you, Munir, for that wonderful contribution. Is Dorothy, is she in? Dorothy? You have just in 1 or 2 minutes because we want to give the faculty 5 minutes to round up. Dorothy, if you're around, can we hear you?
Thank you for the chance. I take this opportunity to appreciate the participants who have attended this our WIBA. Despite the tight schedule of the professionals, you have made it, you have attended, you have heard what we have in our minds and how we have strategized everything. I thank also the team for the teamwork and commitment, especially with the different times scheduled in their countries. they managed to take their time and be together and compose what we have presented. I also thank and appreciate the Boost leader teams, leader members, Mr. Peja, MJ, Liz, Zineth, Nina, for the wonderful support, made to us team, so that we reach where we have reached today. I thank you and appreciate your support. Continue with that so that we can be a Boost member, a team, a bigger team, a wonderful team. Thank you. Over.
Thank you, Dorothy. Today, fortunate enough, who has been battling with a lot of connectivity issues, it's a bit better. I know specifically for today, I'm sure Dorothy must have climbed a hill so that she can put an antenna so that we can clearly hear her. It was a wonderful contribution. Over to you, Liz. I'm sure you will round up. We want to thank everyone for coming. So over to the Boost community. Liz, over to you for your closing.
Great, thanks so much, Emmanuel, and thank you. Special thanks to the entire team for a really excellent presentation today. I just have a few next steps. One, I believe in a second, MJ will circulate the survey to share your feedback on today's session. This is really helpful for our presenters to get some feedback, so appreciate you filling out that survey. I also just wanted to share a few Boost community offerings that we have currently and upcoming. So last week, we released the COVID-19 Listening and Learning podcast. This is part of an ongoing learning series around COVID-19 vaccine rollout, where a number of our members and partners share experiences in disseminating the COVID-19 vaccine in their communities and countries. So I do encourage you to check out the podcast if you haven't already. We already have 2 episodes up, and they've already been very well received in the community, and you can listen to them at your own convenience. And then another offering that we have is an upcoming training on responsive feedback, and this is going to be hosted by our partner, The Curve. It's going to be a 4-week training that will teach the principles of responsive feedback, which is a process that helps practitioners use data to make better decisions and increase program success while active in the field. So the first session will get started in mid-October, and the application does close by the end of next week. So if you have a chance, please do check out that training. And if you're interested, please apply before the deadline. I think with that, that's all that I have from my end. I don't know if Emmanuel or other team members want to say any closing remarks.
Yes. We, just like what Dorothy has initially said, we want to thank the Boost community for taking their time for giving us this training. And for those who are not part of us, you could see what we've gone through, and you are yet to see. Maybe this is just the beginning. And then you'll continue to see more of us, because this is what we have achieved. We want to thank Peja, especially from People, Power and Health and his team. I want to equally thank MJ, Nina, Zined, Liz, and all other wonderful people from the Boost Studying community. They're really wonderful. They've taken their time to train us, and then we will, obviously, we've taken that pledge that we'll go out and explore. We'll go out to do more. I want to thank you so very much for all you have done to us. There's another, you can log into another one, the 30th. That will be the last, the team will be equally presenting on the 30th. So you are equally advised to log in, and so that we all participate together. Thank you for coming. It's been a wonderful moment. Dr. Hileros, thank you. Dorothy, well done. And Tina, you've done well. Munir, thank you. See you again. It's been a wonderful session. Thank you, Liz. Over.
Great. Thanks, everyone. Have a wonderful day, and hope to see you on Thursday.
Right.
Bye.
Thank you. Bye. Bye.
Bye, bye, bye.
Bye.
Goodbye.
It is wonderful.
Bye-bye. Bye-bye.
Yeah, thank you, everyone.